Everybody to this first grand round of the sarcoma domain of Hurricane. It's the first one. We will hold these grand rounds each month, exactly every first Friday each month, and they will be devoted alternately to discussing a clinical study, potentially practice changing, and the other month we would discuss some clinical scenarios, clinical case, typical clinical case, trying to agree on the probabilities involved. We will have guests also outside the 60 centers of Hurricane, but in principle, these grand rounds will be limited to the 60 centers of the sarcoma domain of Hurricane. We will have guests, however, from the US and from Asia Pacific, just to give us a perspective outside Europe of on what we will be discussing. Today we have Patricia Pautier with us, and we will discuss the French clinical trial on Doxorubicin versus Doxorubicin plus Trabectedin, which was published in 22 and then reported in 23 with the survival data. It's potentially practice changing, but I think it's maybe interesting to discuss how. For example, imagine this leiomyosarcoma patient. Okay, will you from now use Doxorubicin plus Trabectedin because the median progression-free survival is the double? Or would you consider still Doxorubicin alone or Doxorubicin plus Dacarbazine, which is another multi-agent chemotherapy, or Doxorubicin plus ifosfamide? Many of us don't use ifosfamide in leiomyosarcoma, but clearly some centers might decide to do it. And would this clinical presentation be different from this one? Borderline resectability, for which, for example, the higher response rate with multi-agent chemotherapy might be useful to make things easier for surgeons, for example. And would this apply the same way to a single lung lesion, where you may also decide to excise the lesion? So when you decide to combine chemotherapy with surgery, would you use the polychemotherapy in spite of the single agent chemotherapy? And what about using stepwisely the drugs in spite of using two drugs front line? In the end, the survival benefit of the ESMO presentation would point to doing this, but clearly. And finally, what about a future clinical study on anything you may imagine in leiomyosarcoma? Should the standard arm be Doxorubicin plus Trabectedin? So I asked Patricia to recall the data. Clearly, we are all very much aware of this data because we are all sarcoma people. So I asked her to briefly recall this data in order to start the discussion. I mean, it will be a free discussion. Everyone can raise his or her hand and make a comment. I received some emails of people willing to contribute to the discussion in any case, but it will be a free discussion. So Patricia, please, the floor is yours.
Thank you very much, Antonio. First of all, thank you for the invitation. It's a great pleasure to discuss with the EURACAN members the last results of the LMS04 study. And as you said, we have presented at the last ESMO meeting the final results of the LMS04 study, which is an academic study from the French sarcoma group, a randomized multicenter phase 3 study, which compare doxorubicin alone, which is the standard of care until now, versus doxorubicin with trabectedin, followed by trabectedin for non-progressive patients as first-line treatment in patients with metastatic or unresectable leiomyosarcomas. So we know that no major advances have been performed since 50 years in soft tissue metastatic sarcomas. And until now, doxorubicin alone is still the standard of care for metastatic soft tissue sarcoma. We know that the chemosensitivity is probably different among the different subgroups of soft tissue sarcoma. That's why we decided to focus on one subtype of soft tissue sarcoma and to focus on leiomyosarcomas. So except doxorubicin, we know that trabectedin have an activity in leiomyosarcomas in particularly after anthracycline failure, and we have performed a phase 2 study of association of doxorubicin and trabectedin in association in first-line metastatic disease in the same patients that we choose for the LMS04 study, and had encouraging results in terms of response rate, but also in terms of PFS and median overall survival, with a median overall survival around 35 months, which was impressive at that date. So since then, we had the results of the TEDI study, which were in favor of a continuation of trabectedin for patients who did not progress after 6 cycles of treatment. That was the base of the construction of the LMS04 study, which have been first reported 3 years ago, and for whom we show that there were an enhancement of the median PFS with the combination against doxorubicin alone. So we have reported at ESMO updated results of PFS with a longer follow-up. Sorry. And the results on overall survival in the last ESMO meeting. Sorry, someone. S'il vous plaît, monsieur, je suis en conférence là. Merci. So the trial was constructed like that. It's a phase 3 randomized multicentric study for patients with metastatic leiomyosarcomas who were randomized 1-to-1 to doxorubicin alone, 75 milligram per square meter every 3 weeks, up to 6 cycles, or doxorubicin alone, 60 milligram per square meter, associated with trabectedin, 1.1 milligram per square meter in 3 hours, every 3 weeks, up to 6 cycles. And for patients who did not progress after 6 cycles, a maintenance of trabectedin, 1.1 milligram per square meter, on 3 hours every 3 weeks until progression, but up to 17 cycles. And surgery was allowed in both arms after 6 cycles in the study. The primary endpoint was the PFS according to central review, and secondary endpoints included PFS according to investigators, the response rate, of course, PFS2, and toxicity and overall survival. So the patients were included between 2017 and 2019, and the hierarchical testing strategy was applied for key endpoints, and PFS1 and 2 were updated with a median follow-up of 55 months, and overall survival was determined in 2023. So 150 patients have been included, 76 in the doxorubicin alone arm and 74 in the doxorubicin plus trabectedin arm, with a median age of 61 years, majority of soft tissue leiomyosarcomas, and mostly metastatic disease. Median cycles were 6 in each arm for the induction and 10.5 cycles in the maintenance treatment. And 3 patients were withdrawal for toxicity in the doxorubicin arm against 17 in the doxorubicin trabectedin arm. And 6 patients was allowed for surgery in the doxorubicin arm alone, and against 20% in the association arm. So the response rate was 37%, sorry, in the association arm versus 36% only in the doxorubicin arm. The median duration was prolonged with the association from 6 months to 12.7 months with the association. The association is more toxic than doxorubicin alone, with grade 3 to 4 toxicities reported in 76% of arm A, but up to 87% in the combination arm, and mostly toxicity were mostly hematologic and digestive. There were one toxic death, but in the doxorubicin arm from cardiac toxicity. So the updated results, with 55 months of follow-up, we confirm the excellent results on PFS with a 63% reduction in the risk of disease progression or death for the association versus doxorubicin alone, with a hazard ratio of 0.37 in the study, with a median PFS of 6.21 months with doxorubicin alone and 12.19 months with the combination. And we saw that around 30% of patients were alive without disease in the combination arm versus only 3% with doxorubicin alone. So with 38% of patients in the doxorubicin arm who received treatment with trabectedin in second line, the median PFS 2 was enhanced with a combination of around 13 months. And what's about overall survival? The addition of doxorubicin and trabectedin to doxorubicin alone provide a clinical benefit in OS compared with the standard of care doxorubicin alone. And we've got median overall survival around 33 months with the associations against 23 months with doxorubicin alone, with a hazard ratio of 0.65, so a 35 reduction in risk of death for trabectedin plus doxorubicin versus doxorubicin alone. So in conclusion, although 38% of patients in the control arm received trabectedin after progression, the addition of trabectedin to doxorubicin followed by trabectedin in first-line treatment of metastatic leiomyosarcomas provided a clinical meaningful overall survival benefit with a 2 years overall survival rate of around 50% versus 70% with the association, and in uterine and non-uterine leiomyosarcomas with no new safety signal. And this data confirmed that the combination is in non-progressive, in first-line combination, able to demonstrate both an overall survival and a PFS benefit in this phase trial in first-line treatment of metastatic leiomyosarcomas. It raises also the question of continuation of trabectedin until disease progression, because we saw that the curves of median PFS falls after the end of trabectedin. And also the question of association in adjuvant setting, and we will see that we will propose a trial in uterine leiomyosarcomas of adjuvant therapy with the association. And it led to modifications in some guidelines. In uterine leiomyosarcomas, in the last ESGO meeting, we show that we've got new guidelines for uterine leiomyosarcomas and also for soft tissue sarcomas in the last NCA guidelines recommendation. So thank you to all, of course, the investigation of the French sarcoma group for the help conduct this interesting trial. Thank you.
Thank you, Patricia. Thank you so much for recalling this data. I have, first of all, I mean, Geneviève is the coordinator of Huracan, so I would like to give him the floor to make a comment, first of everyone. You are muted, Geneviève. Geneviève, I'm not sure. Do you hear me?
Can you hear me?
Okay, yes.
Okay, okay. So, sorry, my line is not too good. This is why I close the video from time to time. And I understand that we are asking a question, but I couldn't hear it.
No, just a comment. I mean, since you said you would like to make a comment, no?
Yeah, that's a personal comment on the basis of the work of Patricia and the collaborators who have changed our standard practices right now in France, with a big advantage that there is no reimbursement question, because trabectedin was never reimbursed anyway. So we can do whatever we think is the best, and the recommendation of the national network has been to propose Trab plus Doxo as a standard first line for leiomyosarcoma, with matching the inclusion criteria of LMS04. Now, things which are becoming a discussion quite regularly are for those tumors where neoadjuvant, not metastatic, but neoadjuvant treatment is proposed, where we have seen the differences in responses and in tumor control, which makes the multidisciplinary tumor board sometimes quite vivid in saying, should we do Dox? Should we do Dox-Trabec, even though this is not exactly the inclusion criteria of LMS04? But right now, I would say that most patients matching the inclusion criteria of LMS04, at least, Patricia will tell us maybe differently in other centers, but at least in large FSG centers are now using Dox-Trabectedin. Again, the question is not reimbursed. It was never reimbursed, but now it's there are generics.
Maybe Sebastian, would you like to make a comment yourself?
Yeah, it is, first of all, again, Patricia, for achieving that trial. I think it's it really has kind of invigorated the discussion of a leiomyosarcoma specific trial. We've had our German sarcoma conference 2 weeks ago, and we've had some very vivid discussion about the conclusions from the trial. And I can tell you it's pretty polarized. So I think we have two ends of, there's this one group who thinks that the trial tried too many things at the same time, and that kind of weakened the conclusion with like Trabectedin maintenance not being randomized, with Doxorubicin as monotherapy being not a standard in their centers, and with toxicity as a problem for many patients. On the other hand, I think there was, and I think it's pretty amazing that this is the first trial in metastatic soft tissue sarcomas to show an overall survival benefit. And that is something that I personally find very challenging not to tell my patients. So I think it's something that people should know about. I am kind of in the group of people who think it is practice changing. It is for us, and I think it's something that we consider in patients that are fit, because we think the combination is quite toxic, and sometimes we cannot go through with it despite dose reductions. But in those where people are fit, and in those where we believe Trabectedin on its own is well tolerated, and in those patients who kind of comprehend that the role of the Trabectedin maintenance isn't really proven by this trial, but still that's what the data is, we offer them to continue Trabectedin as one of the aspects of the trial. I've treated now, since you presented the overall survival data, quite a few patients. My personal experience, and again, this is a personal experience, is that I see more objective remissions, deeper remissions than what I observed with Doxorubicin, dacarbazine. I truly believe that what you observed in the trial in terms of the objective remission, that this is real, so that we can really get a lot of cell kill, which I think is not that common in leiomyosarcoma. I think in general, it's a sarcoma where objective remissions are less common. I know we have a very large retrospective analysis that is in a way comparable from just looking at the numbers. But again, we know that very often we have, in retrospective trials, we tend to overestimate the activity. So on the other hand, our standard of care, I would say, in patients who are fit for a combination is Doxorubicin, dacarbazine, until this trial was the case. So I would agree with kind of the controversial group that Doxorubicin as a standard is probably not reflective of what many of us do. But on the other hand, it's what is kind of the international standard, and I think it's an okay, fair comparator. But I mean, we can of course discuss that. I think at the moment the data is as it is, and we have a prospective randomized trial that has a very, very impressive overall survival benefit. And we have, on the other hand, a drug that in my experience is well tolerated, like Doxorubicin, dacarbazine. But again, it doesn't have that clear evidence of a survival benefit. So I would say for our center, for fit patients, for patients who have symptomatic disease, for patients where we think, oligometastatic, where we would think about surgery. To be honest, I am kind of opposing of doing metastatic surgery in leiomyosarcoma, because I had the feeling that it's so rare that we actually can achieve cure. But if we get a lot of cell kill, I think this is something that could be changed with that very powerful combination. So I would say that's my main take-home message, but we are faced by the same problem as Jean-Yves has alluded to. The combination itself is not approved in Germany. I actually didn't know exactly what Jean-Yves meant with it wasn't approved before, so you treat it anyway and paid it out of pocket, or I'm not sure what that actually means. For us, it means if we use it as a combination, we risk of getting sued and not being reimbursed. So it's something that we may need to discuss on a national level, whether we apply on a national level to have this reimbursed as a combination, because as a combination, it's not approved. So
maybe we could ask from a different perspective, also from the regulatory point of view, to Shreyas what he believes about all this.
Yeah, no, so I think I agree with the comments that have been made. I think we would all acknowledge and agree that this is a difficult histology. There may be several options, but none of them are a home run, as we call it in baseball terms, for example. None of them are a clear winner, if you will. Attempts at trying to find newer treatments have not been very successful. So I think with that background, trying to rearrange the available therapeutic armamentarium to come up with something that may just have even an incremental benefit with manageable toxicity is welcome, right? So in that context, I think the data is clearly encouraging. It's definitely interesting. Important to point out that you know, the LMS02 data, the single arm data, almost suggested that there is synergistic activity between the two. Is it the 3-hour infusion? Is it that the two drugs are doing something different mechanistically? Why the response rates were so high and reflecting in PFS and OS? As is very typical, I think when you take that to a phase 3 study, the response rates almost get cut into half. But that's still, I think, of interest, right? So I am particularly not so fixated on trying to define the frontline therapy for metastatic disease, right? It's still going to remain an incurable disease. There can be differences in philosophies, and the personalization from the patient standpoint and selection of the therapy, as Paulo, you outlined very nicely at the very beginning. Several factors go into the decision. Do you use one agent, combination, which combination, that sort of stuff. But given that this has shown a interesting enough response rate, a tolerable profile, and some impact on PFS and OS in the advanced disease setting, acknowledging the variables that Seb just outlined in terms of who got surgery, who didn't get surgery versus maintenance trabectedin. With all of those caveats, I think the interest from my standpoint is more so to bring this in the earlier line settings. And of course, there are plans to go ahead with it. I think on the North American side, one of my younger, brighter, more energetic colleagues, Dr. Nassif Haddad, is proposing a intergroup trial to look at randomization to adriatrabectedin versus gemdocetaxel in high-risk localized leiomyosarcomas in the adjuvant setting, if you will. The final comment I will make is this practice changing for us right now? I think we're certainly interested as a group. We are trying to gain more experience. I think the doxorubicin, ifosfamide, doxorubicin, dacarbazine combinations certainly have their own flaws that everybody knows well. I think this is a very good alternative to at least work more with, to try to see where it will fit eventually in the therapeutic armamentarium. So I think my summary comments are definitely interesting, maybe a lot more relevant in the earlier disease site settings, but also an option for the advanced disease patients.
Because maybe a question could be, should we read the study as just saying that trabectedin and doxo are better than single agent doxorubicin, or could we reason that the study, in a sense, is even more important? So it shows that a multi-agent chemotherapy in leiomyosarcoma can give also survival improvement, not only a progression-free survival improvement, and that this progression-free survival improvement could be quite significant from the clinical point of view. So in terms of, say, 1 year or so for at least a proportion of patients, at least 1/4 of patients actually had a progression-free survival longer than more than 1 year in comparison to the standard arm. And therefore, maybe even dacarbazine could give the same, especially if, as in the European environments, we may not be able right now to use Trabectedin. So couldn't we believe that the message is about the combination, so combining 2 different drugs is better than one, and in leiomyosarcoma, for some reasons, this benefit may be higher than on average in other histologies. And secondly, that maintenance therapy may be important. And by the way, also dacarbazine could be maintained, as Trabectedin, also gemcitabine. So shouldn't we read this trial as telling us 2 pieces of information, that probably in leiomyosarcoma a multi-agent chemotherapy may give more. Secondly, that some kind of maintenance in the advanced disease may mean something.
I think
I would probably comment on the question of maintenance. You remember, Paolo, we did a randomized study of maintenance Trabectedin in sarcoma. Maintenance only with Trabectedin, 6 randomized +6 versus top. And this study was not particularly positive for leiomyosarcoma subgroup. It was positive for the liposarcoma subgroup. So that's something which was not meant to address the question of subgroups. We are speaking here of subgroups, but there was no difference in survival and only the difference in progression-free survival in the whole series and in subgroup of liposarcoma. So that's probably one element of discussion. I'm convinced personally that both components were important in the results achieved by the trial.
Javier?
Yeah, one first question for me is it right to make the comparison with monotherapy with doxorubicin? And my reply is yes, of course. Even more because we obtained, the study obtained survival benefit. And so far, as Sebastian remarked, is the first study in the last 40 years that the combination, the doxorubicin-based combination is superior than doxorubicin alone. So this comparator of monotherapy, I think, is legitimate, is right, in other words. It's true that we are not used to plan to design the clinical trials according to the aim, because maybe if we design the studies according to the aim, for instance, in oligometastatic disease, if there is a surgical rescue in the horizon, maybe the difference between chemotherapy in combination compared to monotherapy will be greater, but neither do we know that, because so far the aim has not been in the design from the very beginning. But I think, there are many doubts after this study, but this study provides us a very, very good difference. In the magnitude of the difference in this phase 3 is remarkable in terms of PFS and in terms of overall survival, and overpassed clearly the updated benchmark of EORTC in terms of 6-month PFS rate, for instance. But saying that, obviously, there are many other doubts left. For instance, we are very convinced that the combination of chemo doublet, doxorubicin plus dacarbazine plus nivolumab, which was presented last year in ASCO, now is under review in JCO. This scheme induced almost 60% of overall response rate, centralized review. But the vulnerable zone of this scheme is precisely the maintenance, because nobody recurred during the combination, but after the 6 cycles, many recurrences occur. So in this regard, the maintenance is also important, as Janif mentioned, and in this case is, I think, very a proportion of the success of this study depends on the maintenance. So I am, in summary, I am very happy for this advantage, this added value that this trial provides us. But it's true, we have ahead other challenges, and we should go forward in the best way, for sure.
Sebastian, you raised your hand.
Yeah, I just wanted to add something that we hadn't discussed. It was a little bit of a discussion during ESMO, the combative ESMO discussion, that the topic of surgery. I personally think it is, I like the fact on the one hand that the trial allowed surgery and to keep patients in. Of course, it added another layer of complexity and questions. And my question is, Patricia, if you can comment on your experience while doing this trial. I know that France has probably the longest experience with that combination. Do you feel that it has changed your practice with these patients, that you are more prone to surgery? I started again that we had over the past, let's say 10, 15 years, we've tended to be very restrictive, different from like NOS sarcomas or like sarcoma, like synovial sarcomas. Because so often we have metastatic disease outside the lung, and with like 2 organ systems affected, we tend to not do metastatic surgery. But when I see a patient with LMS now that has really a deep response, my feeling is we tend to think about surgery a bit more. And do you have any feeling of, I mean, in that trial, as far as I understand, there were more surgeries in the combination arm. And do you think that experience of seeing these responses has even triggered surgeons to be more active in surgery? Or is that practice anyway? Because it's not really practice in Germany, I would say, to do a lot of metastatic surgery in LMS, because as Paolo has pointed out, it's typically not a curable disease, and it's so difficult to measure what benefit patients could have from surgery. I do believe in surgery if we have truly cell kill with the microscopic disease as well.
Yeah, thank you for the question. I think surgery is important in oncology. I'm a gynecologist oncologist. So in ovarian carcinoma, for example, we know that surgery most of the time do not cure our patients, but prolonged survival. So in my practice for the leiomyosarcomas or other uterine sarcomas, surgery is one of the big part of the treatment. And for patients who respond to chemotherapy, first-line chemo, whatever the first-line chemo, surgery is a good option to prolong survival, not to cure patients. Most of the time we do not cure them, but I think we prolong survival with surgery. That's why we include surgery in this trial, because it's a real life trial. So for me, it's important to add surgery, as of course the investigators want, in the part of the trial. And secondly, the maintenance treatment of course is another question. And we have performed a pooled analysis between the LMS-02 where there was only 6 cycles of doxorubicin trabectedin without maintenance, and the LMS-04 study. So in this pooled analysis, we've got 3 arms: doxorubicin alone versus doxorubicin plus trabectedin without maintenance versus doxorubicin, trabectedin, and maintenance treatment. And for the moment, we just only analyzed the PFS, but there is a difference between doxor alone and doxorubicin alone. And there is a difference between doxorubicin plus doxorubicin alone and doxorubicin plus maintenance. So it seems that the association is better to doxorubicin against doxorubicin alone, but also that maintenance treatment seems to be to add something in the PFS, at least in the PFS, for our patients. And I think surgery also is, of course, a part of the interest of the study.
Yeah, but
maybe 2 comments.
Sorry.
So again, it's to me the challenge, of course, is we cannot tell patients it's proven. That's one of the problems, because we can just say the whole package is better than doxorubicin. We cannot say that maintenance is better than no maintenance, and we don't, because it's not tested. So it's the whole package.
Yeah.
And that kind of creates a challenge for me. And in practice, I've made the decision again to be selective in terms of fit patients. I wouldn't do maintenance if patients have a lot of side effects. I stop then, just because it's such a, it's sometimes trabectedin is quite, is poorly tolerable.
In the study, there is a lot of stop of
but it's
for
the
toxicity in both arms, but more in combination arms.
But it's clear.
That's right.
For patients, I think it's important that they know there is a combination that has a substantial survival benefit and that cannot be neglected. And it's a challenge when, of course, I think doxo-DTIC dacarbazine is better tolerable. I would say it's a great combination in terms of quality of life. But
yes, but we have not randomized trial which prove that it's better.
We don't have the luxury of having the direct comparison. For me, it's clear that any future trial is problematic in terms of doxorubicin monotherapy, particularly with lurbinectedin. That's kind of a challenge. But I was wondering, to the group, surgery in metastatic disease, again, what is your threshold of offering that? Because again, metastatic sites are different from many of the extremity sarcomas. So it's more hepatic metastases, more outside of the lung. Which patient, I mean, do you do multivisceral surgery for metastatic disease in this context? Is there like any kind of consensus? My feeling is we do much less surgery than in patients with UPS, synovial sarcoma.
Okay.
The typical extremity sarcomas.
Since I had I mean, there was Dario Callegaro who wished to say something on this. Before this, clearly, Patricia, when you look at progression-free survival, it's not enough if you compare doxo plus trabectedin versus doxo. Clearly, I mean, as long as you maintain trabectedin, I mean, this should be compared with trabectedin on relapse, possibly maintained, no? So the first progression-free is not that meaningful. You should wait for a second progression-free, giving trabectedin at relapse and possibly maintaining it. What is, however, important of your results is the overall survival benefit, because as Sebastian said, this proves that the package works. So you have an overall survival improvement for doxo plus trabectedin, and trabectedin is maintained, and there is a benefit in survival. So this clearly overcomes the problem with progression-free survival, which clearly is not that meaningful when you compare I mean, one drug with two drugs, it's clear that two drugs with one of them maintained is better than one. But I mean, it's unless you compare doxorubicin plus trabectedin at relapse, and you see the second progression-free survival versus the first one. But I mean, what is very interesting of your results is that you have a survival improvement. Clearly, this has to do with a package, so with both the combination and the maintenance, but this has to do with any clinical trial. Any clinical trial, of course, tries a package, and then it's a further research question, possibly to split the components, the two components in this case, and try to understand which is more important. But I don't know if Dario wants to comment about surgery.
Thank you, Paolo. I feel I'm on the spot right now.
Okay.
So sorry I missed the first 30 minutes of this meeting. I agree that the package of combination surgery, when indicated, and maintenance is working. And the results of this trial are so solid throughout the time, and considering also the phase 2, and so it's really working. What I always try to ask myself is, who is the ideal candidate for this package? Because of course, all of the patients were included in the trial. And now it's hard to understand the relative contribution of each of these parts to the survival benefit that is no doubt absolutely real. So I wish we will have a nice description of the patients that are included in the trial in the two arms in terms of disease burden, in terms of whether in these patients in the two arms, a rescue surgery might be down the line or not. And this will help us understand more who are, in my mind, who are the best candidate for this kind of package. So who are the patients that might accept a higher toxicity to gain a survival benefit. So in your opinion, Dr. Pautier, if you had to choose, what would be the ideal characteristics of a patient to be offered these treatments, the experimental arm of the trial? Who do you think benefited the most? Or do you think the benefit is there regardless of all of the disease burden and on whether the surgery will be an option down the line or not?
Of course, patients with oligometastatic disease and who respond to the association is the best candidate. And surgery was allowed, but only for patients who can have a complete surgery. It's not in the trial. So I think the best candidate, of course, is responders with oligometastatic disease for metastatic patients, of course.
Genevieve?
I was wondering, Patricia, you did a sensitivity analysis removing the operated patient, did you?
In the first publication, yes. But there are only 20% of patients who have been operated in the combination arm. Most of patients have not been operated.
I have Paul Yote, you raised your hand, if I'm not mistaken.
Yes, I did. I don't know if you can hear me well. Yeah, okay. I am sorry for being late in the meeting. I wanted to add a comment from the surgical side that in general, we look at the prognosis of survival before deciding on the type of treatment. So there's more invasive treatment and less invasive treatments. And we balance that with the survival of the patient. And we, in oligometastatic disease cases, with a prognostic survival of over 1 year, we tend to go for wide en bloc resection like we do in primary sarcomas. Then we reconstruct with large prosthesis and in a patient with poor prognosis and multiple lesions. We aim more for quality of life, and we try to stabilize and treat the pain. So that's more general comment, but it's not written in stone. So
I see Lorenzo D'Ambrosio has a comment.
Yes, thank you, Paolo. Thank you, Patricia, and all the French colleagues for running this trial. I think that in the end, it is a very nice trial, despite all these potential issues that were already discussed. I have a couple of questions regarding especially the fact that if you look at the survival curves, more or less, the benefit is driven by 10, more or less, 10 patients. If you look at the number at risk of the patients. So I was wondering whether you have the data regarding the fact that the patient who underwent surgery did progress or not in the end. And this is one. I think that another important point of this trial is that what is very interesting to me is also that you have a very low rate of progression during the treatment, because at first evaluation, you had more than 92% of the patients who had at least some stable disease. So I think that this is another interesting issue. Following also what Sebastian said, in our retrospective study on doxorubicin, doxo-IF, and doxo alone run with you in the OTC, we had not so far performance of doxorubicin, despite, of course, this was a retrospective study, so it is not fully comparable. But the performance of doxorubicin is probably can be considered slightly lower if you look just at the numbers, because we had a progression-free survival of 9 months compared to 12 months that you had, as well as in terms of response rate, with all the limitation of evaluating response rates in a retrospective fashion. We had 30 to 35% according to the different populations that we evaluated. In the end, that retrospective data were pretty consistent with also prospective ones, because the performance of doxorubicin and also of doxoifosfamide in the ERTC prospective trial were pretty similar, and the doxorubicin alone arm did more or less the same as in your arm. So the retrospective data are once again retrospective, but not to throw out in the end. But I was curious to know whether you have this hints regarding a patient who underwent surgery.
No, we have not the data for patients who have been operated.
Okay, thank you, because I think this is pretty interesting, because in the first
Yes, we can ask.
analysis you showed, and it was very nice to see that the benefit was more or less present regardless of surgery for what concerns PFS. But we do not have yet, I guess, the data for what concerns OS.
Yeah, it was not collected.
And don't you have data about the crossover? I mean, the virtual crossover. So what happened to I mean, how many patients at least crossed over, as a matter of fact, outside the protocol to Trabectedin on the...
Yes, 60% 60% of patients received Trabectedin in the doxorubicin arm, 38% in second line, and the rest of the patients in third or fourth line.
Sorry, may I ask another thing? Just a practical one.
Yeah, please.
Do you, maybe more in the practice, since you are using more and more, I also discussed this with Axel in Lugano. Do you try to use dexamethasone premedication also with the combination? Because this is starting from the day before. Because in the trial, it was
only 30 minutes before. No, we don't.
Just before.
Yeah.
Because
it seems that it's yes. Now I will, because it's better tolerated.
Yeah, because
particular for digestive, toxicity. Yeah.
Because basically I suggested to do it the day before to my colleagues from the gynecological groups that use the PLD plus, and they found a benefit. So it is probably worth to look at this.
So the next question was already posed by someone. What about the control arm of future studies? So you have an ongoing trial with doxorubicin alone, no, as a control arm. So what do you believe about this?
I think doxorubicin alone is not the control arm now. It's not the standard for leiomyosarcomas, I would say.
Okay, so I mean, this implies that that all randomized trials today should have doxotrabe as the control.
I think yes.
Okay.
Yeah, I think that's difficult. That's difficult if you want to have PFS as the primary endpoint. It's difficult not to put the package as a standard. If you want to have survival, you can debate, of course.
And one of the challenges is also who defines as a patient able to receive Trabectedin. I would say I do treat patients with doxorubicin alone if it's clear they are not fit, but those wouldn't be the ones who should be randomized to the combination because they are not fit for the combination. So I think there would have to be a bit more understanding of what are the candidates for a trial. Is that something, because I think it again makes future trials in LMS more complicated if we have Trabectedin as a control arm. It's clear there will be, I don't know, 30% less patients who would qualify for that, maybe even a little more.
Yes, I think we have to work on it, in particular for older people, but we recommend to have a geriatric evaluation for patients older than 70 years old. But for the other one, we have to respect, of course, all the biological inclusion criteria, at least the hepatic and renal function. But
it means that for such a trial, it's questionable to have something else than the combination as the control or a combination. The problem is that we don't have the head-to-head control, the head-to-head comparison with doxorubicin, dacarbazine. But I would say for sure that you can give dacarbazine to more patients, way more patients. I would be much more comfortable to treat patients above the age of 60. I'm not comfortable about the combination Trabectedin in those patients. I know it's arbitrary, the age is arbitrary in a way.
Yes, because we've got some older patients who had received the combination without any toxicity. Yeah. I think the age is not sufficient to select patients. Of course, older patients older than 75, it's an issue, but before 75 years old, it's not sufficient to select patients.
Because I look now at, I don't know, 15, 20 patients that I've treated. I'm just saying that the remissions are deeper from what I know compared to my gut feeling from dacarbazine, but the toxicity is also
yes, it's more toxic, clearly, but it's manageable. It's manageable most of the time.
Yeah, again, but I mean, we are talking about palliative treatment, so I think we still have to keep in mind that we cannot push people through. Again, I've seen some patients who really have gotten much worse in their performance status. So I'm just saying that for future trials, we'll have to really think wisely how we include patients. And again, then these should all be fit for combinations.
Yes. I think performance status is one of the most important inclusion criteria for the association, but not the age.
But we do treat doxorubicin ifosfamide older than 65 if they are fit. That's really a general question on which section. Other less than 50 are not fit for anything else than doxorubicin.
Of course. Roberta?
I have a question for Patricia and for the other colleagues. As we assume at this point that adriamycin alone is not a standard anymore, what do you think about the ongoing study of lurbinectedin and adriamycin, which is randomized versus adriamycin alone? Is it still an ethical study? Do you think that we can just in those institutions where the study is open, is still ethic keep on going to enroll patients into the study?
It's a real problem for me, because the interest of lurbinectedin, I think it's because it's less toxic probably than trabectedin, but we have no idea of the efficacy of the association. The scheme is quite the same, association and maintenance, and surgery for patients who can have surgery. So I'm concerned with this study, because perhaps it will be better to compare the two schemes and to see if it's equivalent with less toxicity, rather than to compare to doxorubicin alone. For me, it's not yet the standard of care.
I mean, it's a conundrum for PharmaMar because it's so hard to imagine that the doxorubicin lurbinectedin will be like easily better than trabectedin combination, and then all of a sudden a trial is impossible to prove that. Luckily, we don't have PharmaMar stocks, so it's not our problems. But I would agree that it's a challenge. I think if patients understand and they say, well, I don't want to have the combination, which I'm afraid of because of the toxicity, but maybe lurbinectedin is less toxic. But I think it's a challenge not to tell patients that there is a survival benefit. But that's what it is.
So if lurbinectedin does look interesting, the next randomized trial could be adriamycin versus lurbinectedin with maintenance in both, right? There you go. We keep running large randomized trials. Certainly interesting comments and great discussion.
Would you buy PharmaMar stocks for that trial?
You think I'm going to tell you that in public? No, I'm joking.
Of course you can.
And you should have doxorubicin.
Are you trying to con me into something?
Actually, it's less us. What do we think? Because I think we all think the same in this present situation than the health authorities. If PFS primary endpoint, what are they going to say if we present docs standard treatment while Patricia has a trial? It can be debated. Also, another aspect is whether Trabec Doxo is available truly in your country or in your center. If not, then that's absolutely ethical, of course. I know that you don't have this problem, Treyas, which is cool.
No, but at Geneva we could do doxorubicin plus dacarbazine.
Yes, but it's not a standard.
It has never been, well, we all know the data. We are all signers of the paper. Actually, it's not superior once multivariate analysis is done. But, well, that again, we need a randomized docs versus docs DTIC as we did in the 70s.
It's the standard of our hearts, Patricia.
Sorry?
It's the standard of our hearts. That's the challenge.
Thank you.
Lorenzo, do you?
No, just a quick comment. First of all, I'm very happy to see that many of us are willing to run the trial that I was trying to push through the RTC for some years. But in the end, it cannot fly. Regarding the doxorubicin trial, I'm curious to know whether there is some way to look at the data from the LMS04 to see whether there are some patients, maybe those ones with small lung lesions, multiple lung lesions that will never operate, where Dox alone can still have a role. Because in this case, we can still consider to have Doxo against Doxo plus something. Otherwise, I fully agree that for patients with high burden disease, doublets more or less should be considered a standard now. Regardless, of course, we are quite used to deliver Doxorubicin, and I fully agree with Sebastian that is really manageable. But also, of course, if you have in your hands Trabectedin is fine as well.
Dario, you have a comment?
Yeah, so I was wondering if you, sorry if you mentioned this already and I missed it, if you have data on other local treatments other than surgery, because if I remember correctly, about a third of the patient had liver metastases. I was wondering if you have data on local treatments other than surgery.
It was not permitted to perform local treatment except surgery.
Okay.
But of course, it's one option. Local treatment include this type of treatment, but not on the study.
And it was not permitted even in
Not
further
permitted.
lines.
Of course, probably some people do have done it, but few people.
No, I mean, I get back to what I was saying before. I mean, as long as in Europe, at least, we may not have access to Trabectedin in first line at the moment. Genevieve, you were saying, okay, in this case, Doxorubicin alone is the standard, but on my side, I mean, in my clinical practice, in a fit patient, at least as long as I don't have access to Trabectedin, I would give Doxorubicin plus dacarbazine, which I assume may be better than Doxorubicin alone. We don't know if it's the same as Doxotrabe, but I mean, I don't believe it's illogical to use a multi-agent chemotherapy with a possibility of a maintenance substituting Trabectedin with dacarbazine, as long at least as we don't have access to Trabectedin. I mean, do you think we need an impossible randomized trial for
No, I'm not sure we need a randomized study, actually. Who would fund such study? But what we definitely need is a real-world evidence, collective collection of data, and see what happens. Actually, we have been doing that in France with a social security system merging with the NetSarc database. This will be sent to ESMO this year, by the way. And this provides interesting, though surprising information. So I think this is the only way. Nobody will fund any study. Now, it becomes something ethical, though. Now that we have a randomized study, which is showing that the package does possibly better in survival, how come that the healthcare system do not provide this service? So I can understand for larotrectinib because of the cost, but yeah, frankly.
Shreya, so what do you think about this from the US side of the ocean?
Right. So I think we are less likely to run into reimbursement issues, right? So the logistic limitations are not likely to be that significant. With the publication that shows that there is a potential survival advantage, I think the coverage for Trabectedin should not be difficult. And we are, like I said earlier, trying to get experience with this ourselves. I think from a toxicity standpoint, those of us who give doxyphosphamide, this toxicity is not that much of a concern. But in terms of, so if your question was directed at, does it change the standard of care? And getting back to the previous conversation, I think it is a very true statement that it is the package that works, right? It's not just the doublet. But the package is the standard of care. I think Seb brought up the issue of surgery. And I think, we in our group have always been very aggressive with surgical resection of residual disease as long as it is completely removable. The problem is then what about one solitary liver lesion? Do you ablate that lesion and still call it resectable? I think those are all variables, I think. But the broader sarcoma management, even in the metastatic disease setting, where feasible, has included aggressive doublet chemotherapy to induce response stability, resect the disease to get them to a no evidence of disease status. And that seems to be obviously predictive just based on historical data for longer term survival, right? So I think Lorenzo made the comment, and I think that was a good comment, that is the survival benefit here driven by the 20% who got surgical resection, right? Is it the oligometastatic patients who could get a decent response and surgical resection rendered free of disease? Are they the ones that are driving the entire cohort? Frankly, from a practice standpoint, I think even if they are, I think in our space, we have very limited level 1 evidence in a lot of areas, right? So I think if a package works where a doublet chemotherapy followed by surgical resection, and in this instance, even maintenance chemotherapy, the adoption is likely to be well accepted, is my 2 cents worth. I don't think the penetration has been that great in the US yet, but I think slowly but steadily it might. I wish we had other colleagues from this part of the world to sort of give us a flavor for what's their practice. We at Anderson certainly are trying to dive deeper into this combination. And like I said earlier, we're even trying to propose a adjuvant trial just for the North American continent to see if we can test it in the earlier line settings.
Hey, Shreyas, in that context, that trial, I was wondering, to me, the coolest trial, if I could pick one, would be neoadjuvant in comparison with doxorubicin, where you could actually use cell death as a dynamic marker, because the hypothesis to me is that this is, I have a gut feeling the combination is synergistic and causes more cell death, but that could be something that may give some more evidence of the true difference in terms of cell kill, which is what I think could be the best rationale for a randomized trial in the perioperative setting.
You're right. We absolutely thought of it and got rid of the idea in 30 seconds. I think this is how we sarcoma medical oncologists think, right? But at least in the US, and I'm sure this is true for plenty of places ex-US, patients with primary LMS, at least of the GYN organ system, come through GYN oncology, right? And I think the standard is surgical resection. I mean, we ran into this business of post-op radiation. It got so complicated. And at the end of the day, the GOG was not necessarily interested in this whole approach. So it's a matter of logistics, but you're right. From a conceptual standpoint, wouldn't it make a lot of sense trying to do it up front, select your patients out, give them the benefit of an aggressive surgical resection, maybe do maintenance post-op, and that could improve the cure rates, right? I think wonderful theoretical hypothesis, but I don't think that's practical, at least not in the US.
Yeah, maybe Elise can comment on this. Why did you choose gem-docetaxel as a control?
Yeah, thank you for mentioning this, Dr. Patel, and thank you everyone for having me. We choose gem-docetaxel, and this is probably also a US problem, but in the US, basically if patients are seen by GYN versus if they're seen by sarcoma med-oncs, they don't get the same adjuvant treatment. Basically, if you're seen by a GYN, you're going to get gem-docetaxel adjuvant. If you're seen in a sarcoma center, you're going to get Adria-based chemo. And so up to now, getting our GYN colleagues to do AI or other Adria combos, they didn't feel comfortable with because those were drugs that they don't know. Whereas Trabectedin, they actually feel comfortable with. So the idea was to actually standardize practice across GYN oncologists versus sarcoma medical oncologists for patients in the US, where really the problem, most patients who come to us have been seen by GYN oncologists, get gemdocetaxel, and then come to us, which is one of the challenges. And that's why we had those we are having those comparator arms.
Thanks. Thanks. No, I was thinking, Sebastian, that, by the way, looking at the pathological response is not that easy in soft tissue sarcomas. So in the end, I mean, and then in addition to that, for example, at our institution, we usually combine radiation therapy with preoperative chemotherapy, such that all the more evaluating the response may be less meaningful, I mean, in terms of understanding whether Doxorubicin is different from Doxorubicin. I mean, but I mean, aside from that, do you agree that, for example, if a patient undergoes Doxorubicin and then surgery for metastatic disease, I guess, then you go on with Trabectedin as a maintenance, for example, after complete surgery, for how long?
Are you asking me?
Everyone.
Anybody? Yeah. I mean, so I'll start since I jumped in. To me, I think it gets back to that basic issue we were talking about earlier, right? What has worked in LMS04 is the package. When you start peeling things off the package, do we really think the benefit would hold? So in some ways, theoretically at least, I think if one wasn't going to plan on maintenance Trabectedin afterwards, that sort of detracts from the combination therapy arm that was tested. How long, I think, is a great question. Is 6 months different than 12 months? Some of it, I think, is going to depend on tolerance and patient preference, those sorts of things. So I would sort of answer the question like adjuvant therapy for just with imatinib, at least 6 months, and then kind of take it from there.
Any other opinion about this?
We have endless discussion at the multidisciplinary tumor board, Paolo, on this very question, and actually for given patients. And usually we try to match the schedule of LMS04, not infrequently, and of course some patients stop before for the reason we have expressed. Not infrequently, this Wednesday we had this discussion, patient is going to continue because we well tolerated, because we fear that, and so on and so on. Not there will never be a study for that, of course.
Okay. But I mean, as a feeling, all of us believe that maintenance therapy may be an important component of this package.
I think so. I think you nailed the two important aspects of this whole trial, right? One, that starting with a doublet makes a difference. As Seb said, the responses are higher, deeper, maybe longer lasting. And two, the maintenance part has to have played some role. Until we prove that it hasn't, I don't know that we can get rid of that.
And I would agree that at the moment it is I would continue and offer to continue, and if patients suffer and it's really not compatible with like participation, that would be for me the cut. But I think at the moment I tell the patients, well, the trial was as it was that package, and people received it for as long as they could. And I would probably continue treating unless it's really affecting quality of life.
And since I mean, the last question, I guess, I got the feeling that there were different opinions among us about the role of surgery of metastasis, of lung metastasis, also in leiomyosarcoma. Are we on the same page or not? I mean, do we use surgery of lung metastasis, for example, in leiomyosarcoma as in the other histologies, or is there any difference in our practice?
So
Short answer on my side would be exactly the same than for others.
Mm-hmm. Sebastian?
So I would say in general, not everything that's technically possibly we would do. And we know that surgeons can do a lot of things. So we tend to be restricted to patients with a reasonable number of lesions. And I think I would be very hesitant to have surgeons operate on 2 organ systems,
Okay.
to be honest.
Shayas?
Yeah, so I think as long as it is, and Sebastian hit it on the head, right? If it's one organ system, if it's just intra-abdominal, obviously not involving visceral, right? If there are multiple liver metastases, it's completely out of the picture. But if it's just peritoneal disease or just lung disease, we will still go after it. If it's lung and something else, then I think it becomes a challenge. And I, the conventional wisdom has been that you don't succeed in terms of longer term benefit if you have to go berry picking in the chest and in the belly and ablate the liver, that sort of stuff.
Okay, any other comment? By the way, I mean, we are at the end of our 90 minutes. Thank you. And our next meeting, by the way, our next grand round will be on May 3, which is the first Friday of May, same time. And it would be a clinical case discussion also. And our idea was to discuss exactly about surgery of lung metastasis and chemotherapy or medical therapy, so the combination and so on. So if our probabilities, I mean, the probabilities we guess, for example, that the patient may be cured or in any case has a long-lasting, relatively long-lasting benefit, are the same or not. So, I mean, it would be a clinical exercise about which probabilities we would guess in these clinical scenarios. So thank you so much for joining, and have a nice afternoon for Europeans at least, and day for US colleagues. Thank you.
Thank you. Wonderful.
Bye.
Bye.
Bye.